All right, I think we will go ahead and start. Welcome, everyone. This is our December 1st update for the Department of Public Health. And oh boy, it's been a very busy week and lots to talk about. So I will just jump right into my slides here. Hopefully you can see them. We're going to talk about metrics. We're going to talk about something that you've probably heard about called the Omicron variant. I don't even know how to say it. Omicron variant. It sounds like, oh my God, which I think is part of the panic that everyone's having, but we'll get through it. We'll talk about oral antivirals and what we know about them, and then just end on World AIDS Day. So in terms of our metrics, here's what we're doing compared to the states in blue. We all kind of had that fall surge, August, September, going into October. And then unfortunately, we experienced more of a plateau and then a rebound, which is now coming down, but we're still not at the same level as the rest of the state. Here's what our curves look like. And more importantly, here's what our hospitals are doing. So again, you see that we had the fall peak and then a little peak, and then now kind of coming down, but still lots of COVID patients. And beyond that, the hospitals are still just at capacity. We had a productive conversation with the state representatives on Tuesday with all of our hospital representatives there. And we were able to vocalize some of the challenges that local hospitals are having. The way that we're looking at it is we certainly hope that this downward trend continues as long as possible, but we know that it may just be, the next couple of weeks when it goes back up again as a result of this winter surge. And now with the news of this new variant, all of that it becomes even more higher stakes, as it were, because this new variant is concerning for a lot of reasons that I will get into. So we have a couple of weeks to really plan and prepare, and that's exactly what we're trying to do by getting all the partners in dialogue and really figuring out what our needs are and how to address them. In terms of vaccinations, I don't know if Joe had a chance to join, but this is a snapshot of our vaccinations piece. And Joe, I don't know if you want to talk about how things are going. I think we're at somewhere between 3,000 and 6,000 vaccinations a week, with half of those being boosters. Those are absolutely important as well. And we certainly hope that you are helping to message to your patients that not only are the vaccinations important, but the boosters are just as important. And hopefully getting that message out, just because we want to make sure people are fully protected as much as possible. And obviously also getting the kids that are over age 5 vaccinated and helping to answer family questions and parental concerns so that we can kind of nudge all of those families to get vaccinated, especially as we have time over Christmas break, so that when people come back to school, that they're fully protected as much as possible. All right, we're going to talk about this Omicron variant. Things have been moving very quickly. Much happened over Thanksgiving weekend. But basically, South Africa has a pretty sophisticated network of genome sequencing, and they noticed that while their fall surge was on the mend, that they had an outbreak in one of their states, and it was really among college kids. And so they said, well, that's kind of funny. Let's try to analyze that. And that's when they first detected this new variant in early November. Mid-November, just depends on what timeline you look at. But basically by late November, it was really obvious that they were dealing with a new variant that had a lot of mutations, especially in the spike protein. So they asked the WHO to convene in late November. And that's when it was given this new name called Omicron, and then immediately made a variant of concern. What I'm going to do is spend a little bit of time on this really amazing slide set that South Africa has released. And to their credit, I mean, these researchers are doing amazing research, top-notch research. And we owe them a debt of gratitude for jumping on this and really figuring so much out on behalf of the world. And almost ironically, the country is now under this really crazy travel ban, which most experts, agree is probably not going to help very much, but we have to do something. So there you go. So anyway, here's their slide set. Basically, the new variant was detected with a high number of mutations The mutations are in the spike protein, which is what is the target of the vaccines. So it sets you up for a prediction of immune evasion. There's also mutations that are similar to Delta and other highly transmissible variants. And so in addition to the immune evasion, this may also have an increased transmission. It's worldwide at this point, so it's not even a South Africa story anymore. It's found in other African countries, Hong Kong, Amsterdam, and now here in California, which I'll get to. But basically, it can be detected by a specific PCR assay. I don't have the details on that, but just keep in mind that not every PCR assay will be able to tell you whether you have this variant or not. There's one assay on the market called TACPath, and that TACPath is available in the US, and that's the one that can actually do an immediate, not only plus or minus for COVID, but plus or minus for Omicron. But beyond that, you have to get whole genome sequencing done. Okay, here's probably the scariest slide of this whole presentation. And this is basically the genome of COVID. And this little colored section is the spike protein. And in that spike protein, all of these lines are the different mutations that they have found in this Omicron variant. About 50 mutations with 30 in the spike protein. And they're very different from other variants of concern. And because this spike protein is kind of where we've put all of our eggs in that one basket in terms of vaccines, people are really worried that all of these mutations will invalidate the power of these vaccines. Now, again, I'm sounding more apocalyptic than I mean to, and that's just because I don't have the words and the vocabulary to be more sophisticated, but that's kind of why this has taken on such energy in the headlines. Again, more language here just for your own reference. There's clusters of mutations that resemble other variants in the past, which we know have enhanced transmissibility and also increased infectivity and possibly resistance to neutralizing antibodies like the monoclonals that we are also using. So there's multiple reasons why these mutations have really raised this variant to a variant of concern. In terms of, all the different states in South Africa, they have great names. They tended to have the beta, then they kind of tended to get the Delta, which is in the red dots here. And then the blue dots are the new variant, which is found in this one state called Gauteng. And that's where they first detected this variant. The things that we still don't know are, we know what the genome looks like, and that's good. However, does this actually translate to more transmissibility outside of colleges in South Africa? That is an unknown. Will the vaccine still protect us? Obviously, a huge question still to be unanswered. What is the risk of reinfection from people that have survived COVID already, from like Delta survivors, for example? How severe is this disease? Is this really going to translate into increased hospitalizations? And of course, how do we pick it up? Will rapid antigen tests work? We know PCRs will work, but we will need to do whole genome sequencing in order to really catch all of these Omicron patients. The first one, the UCSF lab basically made an announcement at 11 o'clock today, and they said they've been looking for the last 5 days. And so they've done probably hundreds, if not thousands of samples, and they found the first one. So that's why they went public with that knowledge. So in summary, sustained increase in incidence really led to this suspicion that there was a new cluster. It didn't make sense why they would have a new cluster when everything else was looking so good. But then they realized that this new variant was, more transmissible, for example, and that's kind of what triggered their analysis. Again, this link that I keep adding to every slide gives you just the whole slide set. I really recommend that you look at it. They actually have a YouTube video. Again, it's fascinating to just hear the South African researchers that are on the front lines tell the story of how they discovered this variant. If you have time to look at it, I'll send you a link to that as well. So freshly after all of that happened, CDPH convened all the health officers, said there is this variant. It's not in California yet. This was last weekend. And they said, here's what we're going to do about it. We're going to put out a press release. We're going to obviously ramp up our surveillance and make sure that we can catch this as soon as it is as soon as it lands, basically, with full anticipation that it would, just given travel patterns. Very shortly thereafter, we put out a press release on Monday just to say the same thing, that we know about the Omicron variant, and we will communicate more information as we get it. So that's kind of where things were until this morning, when basically the UCSF lab detected a case in California. This was interesting. This was a traveler from South Africa. They landed, I think about 10 days ago. Probably some of you know the story better than I do at this point. I've been in meetings all morning, but I'm sure this is all over the news. But basically, this person landed a few days ago, had mild symptoms. They're not hospitalized. It's an adult female who is vaccinated but not boosted. So that's what's interesting, is that this person was vaccinated. They had their first 2 shots, presumably, but did not get their booster. And so that just kind of opens up that whole door of like, is the booster really the key to preventing this variant from catching fire here in the States? It's such an interesting story, and we're all learning hour by hour as it unfolds in real time. The joint statement is also available online from the San Francisco Health Department and CDPH. And that's really all I know about the Omicron variant, or Omicron variant, sorry. It's really hard to mispronounce. Some people call it the omnivore. Some people call it the oh my God. I'm sure we're just going to call it, OMG before long. Anyway, any questions or comments or information that other people have that it would be good to share at this point? Good news about crab cakes. Okay. All right, let's talk about the new antivirals. So there's a new one that the FDA panel that makes the recommendations. It was reviewed yesterday, and I think very late yesterday, they said, we will narrowly approve this for an EUA, and now it has to go to a couple more steps, like the ACIP committee and the CDC will need to also approve it. And then it will be available for use. So what is this? This is an interesting medication. It's actually been around for years. It was an anti-influenza, an antiviral, kind of just a generic antiviral that was kind of sitting on the shelf. And it works by basically making the virus make bunches of mistakes in its DNA copying. And so it basically, instead of stopping the viral transcription, it actually just makes it screw up. So it's called an error catastrophe mechanism. The word molnupiravir is actually named after the hammer of Thor, which is Mjolnir. And just like a Marvel movie, it's actually getting panned even before it gets released. So basically, people are already casting doubts about its mechanism, the fact that it's only 30% protective, the fact that the study seemed to have like 50% efficacy, and then they dialed down the efficacy by releasing the full results of the study. And just this mechanism of action, which is that, it's messing with people's DNA. All of this is really raising a lot of concern. So even though it passed very narrowly. And so don't just look at the headline with this one, look at the fine print as well. I think there's going to be a lot of caveats, a lot of qualifications about who exactly will benefit from this. And at the end of the day, the advisory committee just said, look, if there's something else that comes out that's even superior in efficacy or safer, then we will definitely pull this product. So they really are trying to approve it with as many qualifications as they can. And I think that that's going to be the theme of this, for better or for worse. In terms of what the state is doing, they are leaning into planning, and they are saying to us at the health departments that once the EUA is approved, the state will allocate to local pharmacies. They're not giving any information about how many doses of pills we're going to get and which pharmacy and how many pharmacies or anything. They've just said they want to use the pharmacy system. And if you have any rural clinics that have pharmacies like FQHCs in rural areas, that we can recommend those sites as well to be recipients of these allocations, just to help with the equity and the geographical distribution piece. So we are working with the state to try to plan this out in its very early stages, even before it has EUA approval. And I will definitely have more news about this probably by next week. So stay tuned. And that's really all I have to say today about the oral antivirals. They're definitely not a substitute for vaccinations. So already please start messaging to your patients about this. Just say, you know, if they bring up the oral antivirals, just say, listen, just get your vaccine. Don't think about these oral antivirals as a substitute. The vaccine is so much better. It's proven to be safe, even in pregnancy, even in kids. And basically that's just a much better strategy for us to be pursuing right now. But, you know, maybe down the line, these orals will find a select population that they benefit, perhaps people that are already vaccinated but have breakthrough infections, et cetera. So that's kind of, you know, more to come about exactly who will benefit and how they kind of list the selection criteria. And keep in mind that Pfizer has its own product. They're touting it as being even more effective, but it has not gone through the same process. And so whenever that happens, again, the story will change once again. All right, any questions about that or comments? I see something in the chat. Okay, yeah. All right, great. So I'm going to move forward. I think my next topic is actually along the same lines, which is our monoclonal treatments. So monoclonals are actually, you know, if you had to compare the evidence about the orals with the monoclonals seem superior because they seem to be more protective than that 30% that's being listed as the oral rate. And so this is, you know, again, the preliminary data suggests a 70 to 80% reduction in hospitalizations. We just put out our new edition of the monoclonal antibody treatments. So that's given at this link. There's also a link to CE from the Mayo group. And they have just a series of great lectures and modules to learn about these monoclonal antibodies. So I included that link for you. And then Dr. Zweifler has very meticulously been creating this table and adding to it, which is so great. So now we've been able to add Clovis Urgent Care. Thank you, Clovis Urgent Care, for providing these monoclonal antibody treatments. So, you know, we really do want to expand this as much as possible so that we can offer this treatment to as many people as possible and hopefully keep them out of the hospitals if they get to this monoclonal antibody treatment in time. Any questions about that or comments from Dr. Z?
Just trying to get off mute there, but no, you covered it well, and we're trying to get it more available in the rural areas particularly. So if any of you out there are willing to take it on, that would be fantastic. There's a dearth of options for monoclonal antibodies in the
one of the calls from this, on the call from the state, one of the things that they offered was they will actually send in a strike team to provide these antibodies if we can just give them a space and we can really guarantee a good pool of patients. So if that fits your bill, you know, if you have a good group of patients that you really are having trouble sending to get monoclonals, and you have a space where the state team can come in and set up a monoclonal antibody infusion site, then please reach out to us, because that would be lovely to be able to use that resource. You know, we're not sure exactly where that would be, whether that would be in a more rural area or somewhere within the city. So, you know, we need you to be our eyes and our ears to let us know, you know, what you're hearing from your patients, what would be convenient, what would work. And hopefully we can figure out some way to, you know, use that state asset. That's something else that we're working on.
And just as a reminder, so it can be given, there's 3 different ones out there. The Regen COVID can be given either IV or sub-Q. So it can be given sub-Q and you can bill for it. So it's I think it's $450 for the administration for the either the IV or the sub-Q form. And if you do it at someone's house or in a mobile unit, it's $750. So there is some reimbursement available. And if there's other barriers, and if any of you out there have mobile units or have some other thoughts about how we might be able to make it more accessible in rural areas, please talk to us, and so we can explore different options for making it more available and accessible in rural communities.
Thank you. This is World AIDS Week, and today is World AIDS Day. So just to give people hopefully a little bit of inspiration, I think the story of HIV/AIDS holds a lot of lessons about how cooperation and optimism and just a persistent focus on good science can actually lead to legitimate progress. So don't give up hope. I feel like this is a pandemic that in many ways, we've been able to claim a lot of victories, and hopefully we can do the same with COVID. But, these are some infographics about the challenge that still remains. There's still a lot of health disparities, pretty much, depending on level of income, level of poverty, level of education. There's still a lot of people here in the US that just are still suffering. They say about 1 million people are living with HIV/AIDS in the US, and worldwide, as you can imagine, in many places that's magnitudes greater. But, think about how you can do the counseling and testing and screening, and obviously offering great treatments at this point for HIV/AIDS in your patient population. It's really one of those things that we shouldn't forget the basics of preventative health and medicine just because of COVID. And we should really double down and take advantage of all the great progress that's been made in this space. An editorial from Dr. Fauci, just, because that's kind of his whole career was really dedicated to HIV/AIDS before COVID came along. And so he kind of has a great reflection in the new Nature about his 4 decades of HIV research that I just included in the notes for you there. And here's testing schedule for December that our department actually supports. It's by appointment. The appointment number is right here in the top left. It's for HIV and Hep C. And this is really something else that we need to talk more about as a community, is how we can do universal screening for HIV, Hep C, and other sexually transmitted diseases, because universal screening is really shown to, pay the return on investment many times over. And it's really something that we need to work together to coordinate in our primary care, our urgent care, and our emergency departments. And perhaps we can dedicate an hour whenever we have time to do that, just about how we can make that happen. And we can invite people from the state that work on this full time to talk about, what works in other counties and how we can get all of our partners to kind of be on the same page and rely on each other. I think one problem is it's hard to do the whole life cycle, right? It's hard to do the history taking, the screening, the testing, the follow-up on the testing, the bringing people back and getting them treated and having long-term continuity. It's really hard to have one clinic that's doing all of that for every single person who needs it. And so there's lots of innovative programs that allow you to divide that labor and for example, have the primary care and the urgent care and the ERs do the testing piece, and then have a navigator system that then plugs people into the referral and care piece. And that's something that we do need to kind of bulk up here in Fresno County. So hopefully we can talk about that. If not this month, then hopefully early in the next year about how we can really do that better. And I think that's all I have. So we'll just open it up to comments and questions if people have them. Thank you very much. Let me see what's in our chat here. All right, Chris is asking people to donate blood. Speaking of getting a free HIV test, I'm sure they will provide that as well, but that's not the best reason to donate blood. The best reason to donate blood is to actually help your friends and neighbors, because we're, as Chris says, constantly on the verge of running out of donated blood products. So please keep that in mind during this season of giving. The best thing you can give is the gift of life, and donating blood is an easy way to do that. Thanks, Chris.
Thanks, Dr. Vohra.
Sure. Any other questions or comments? Just going back to, we're going to continue to be inundated with media blitz about this Omicron variant. In terms of what you need to know, just be on the lookout for, folks that have traveled, definitely from one of the higher risk countries that have reported illness. Obviously, they should have been screened when they traveled at the airports, but provided that they didn't, get picked up there, then really just get a good travel history. And if you do have a suspected case or someone that you need tested, then reach out to us so that we can put them in the higher priority queue to get the whole genome sequencing done. It will still probably take 2 to 5 days and maybe even up to a week or two. And don't give the patient the expectation that they will find out what their variant status is. The state is pretty clear about that. They want to know the variants denominators and numerators to do epidemiology. They're not really interested in closing the loop and telling patients what their variant status is. And honestly, I think I agree with that because it's not like we change our management based on the variant status, right? So really, this is an epidemiological tool. I think at some point it becomes evident which variant is dominant. Like with Delta, it became very evident that this was the dominant variant. But now that we have another potentially, transmissible variant like Omicron in the picture, there's going to be a time when some of our cases are going to be Delta, some of our cases are going to be Omicron, and some of our cases are going to be none of the above. None of that really matters based, in terms of how we treat the patients. We really treat them based on their symptoms, their risk factors, and really triage them to get monoclonals and things like that, just based on their history. We don't look at the variant status at all. So just kind of set expectations, just because you're going to get a lot of questions probably from your patients about what this is, and just let them know that, these variants are really epidemiological tools. They do lead to changes in how we look at transmissibility and hospitalization rates. And obviously, if they end up being able to evade vaccinations, then everyone will find out sooner or later that the vaccines aren't going to work as well against this new variant. And then we'll just have to wait for our scientists to tell us what to do in terms of do we need to really get people boosted even more aggressively? To me, it's like 100% at this point. Is if you got your vaccine 6 months ago or longer, then you should just go get a booster. I mean, I know that the FDA and the CDC took a lot of criticism for waffling on the selection criteria, but I basically early on said everybody needs to get a booster, and now the CDC and the FDA are basically saying the same thing because of this Omicron variant. But nonetheless, there's a lot more to learn together. That's what this pandemic makes us do. Is we can't ever get comfortable with the knowledge of the past. We have to stay current and absorb new information as it comes, and be able to filter good information from bad. So we need to rely on each other to do that. I appreciate all of you sharing your information and concerns with us, and we're committed to doing the same for you. Any other questions? All right, well, I think we'll go ahead and adjourn, and we'll send out these notes just right here in just a little bit. Thank you so much.